We're just here to talk about whether this is right for your practice, for a practice, and what considerations should you have when you're thinking about becoming a semaglutide provider for your patients. Is this something that should be done in a med spa setting? And I've got my wife, Julie, here tonight. She was the brains behind our semaglutide program, which we just really launched actually today. I mean, we've been all doing it ourselves to kind of work out the bugs and, figure out if it's something we want to offer to patients. And we decided to do that. So as I said, we had our first consult today. We have a few more scheduled for tomorrow. So we're going to launch it. For those of you who, may not know exactly what we're talking about, semaglutide is what people are using now for weight loss. That's been called Wegovy is one, and
Wegovy and
Ozempic
and Saxenda,
Mounjaro.
There's a whole bunch of them now.
And these were so hard to get that basically we've all had to do the generic, which is a lot less expensive, as all generics tend to be, and just as effective. So. It's a run. It's like instead of a run on the bank, it's a run on the pharma companies for their semaglutide.
Right. Well, it's not exactly generic as you would in traditional pharmacy, where once something is on the market for a long time, it becomes, generic. It's not that. It's compounded, which is different.
That's a good point. Yeah. So it's from a compounding pharmacy. The patent is still in effect for the other drugs that she mentioned. But nevertheless, will it be available through MAA? Yes, it will be. Julie's kind of running that and heading that up. So and Victor. So all of you can get involved. You might want to call. Would Aaron be the right person to call for?
Aaron or Julia, and I think currently Victor is going to schedule some training sessions, some Zoom. If you will, so that people have options to learn about it.
We'll do a kind of a round,
and get all the paperwork and know what you have to do and all that. But we can talk about some of that.
We'll do a round table Zoom to sort of say, hey, this is what you should do. This is how you should roll it out. But just in terms of how it works, right? There's glucagon-like peptide 1. So you'll hear people talk GLP-1. So basically, what happens when you eat something? It starts to percolate, goes through your stomach, gets broken down, goes into your small intestine, and then your colon, and then out the other end. And when that process is happening, this GLP, this glucagon-like peptide, is secreted from the distal ileum in the colon. And when it gets into your bloodstream, it goes to the pancreas, and it says, hey, pancreas, you better produce some insulin because we got a load of food coming your way. And then it sends a signal to your brain saying, hey, we're full. The bowel's getting full. Stop eating. You're not hungry anymore. So it sends a signal to your brain saying, we're full. And then it also slows down your bowel, right? So your motility is slow. So all these things are like going to stop you from eating. So here you get the same effect without really eating anything. You just inject yourself once a week, and you build up over time. So you go from 0.5 milligrams, 0.25 to 0.5 to 1.0 to 1.7 to 2.4, which is your full dose. Right. Exactly. And each of those doses lasts 4 weeks. So it takes you 4 months.
5.
To get
4 months.
To get
on
up
the 5th month, then you're at your
2.4
maximum dose.
So it goes up slowly. And there are definitely some considerations. Number one, let's just talk about the contraindications, right? So if you have a history or your family has a history of medullary thyroid cancer, can't do this product. If you have multiple endocrine neoplasia 2, which is medullary thyroid carcinoma, parathyroid tumor, and or pheochromocytoma, which is an adrenal tumor, can't do this. And also gallbladder disease rules you out. So other than that, I think everyone's fair game. Pancreatitis, right? Anything that's had a pancreas problem.
Right.
But there are side effects. Everyone. We were just, in fact, was scrolling through my phone right now. It's like a little chat group about all the
all the
staff's like side effects from this. And if you look at the literature, the number one, I guess you'd call it a side effect, is adverse event. Maybe it's a better term. Nausea, diarrhea, vomiting, constipation, abdominal pain, headache, fatigue. We were just talking about this in our group. Dyspepsia, burping, dizziness, you name it, it's happened. But obviously they're all GI oriented except for the headache component. None of them are really severe. No one in our group has stopped taking the drug because of it. Everyone has lost weight. Most people just describe that they become indifferent to food. Like, I guess I should eat because I haven't eaten anything. Julie called me yesterday and was having like headaches and just nausea and stuff, and she just hadn't eaten all day. So I said, eat something, and she ate some bread and felt better. So it's like, it's like, obviously if you're hypoglycemic and you're going to be having a headache and not feeling well, so you have to be sure to eat. It's a nice way to combine like a low carb diet or a healthier diet with this diet, because you're not eating very much, but what you're eating maybe should be healthy, drinking plenty of fluids, because constipation is a real issue. And keeping your activity level up, trying to exercise. So you're kind of like getting healthier, but you're also using a drug that's telling your body that it's really not hungry, and it's cutting down on your appetite. So like we had a dinner for MAA last night, and we went to this nice steakhouse with Chris, and I knew that if I just ate some bread and stuff, I would be full, and I didn't want to do that because I wanted to have a nice steak. So I had like a little salad, and I had like one bite of bread. And then when the steak came, I like ate 4 or 5 pieces of it, and I was just like, I can't do it. So I could do it. You could force yourself to eat, but what happens is your stomach doesn't empty, and you regret it for the rest of the night and into the next day, and you start burping and everything. Protein, lots of water. Be in your lab. But we can't really have anyone else in the live video right now because we have a lot we want to tell you, but thank you for asking. So one of the other things we talked about is, okay, so since you're a provider and you're putting someone on a medication, right? That's it's a hormonal, it's a peptide that's changing the way your body works, right? So what responsibilities do we have as clinicians to make sure our patients are healthy, right? To make sure that there are no contraindications, that we're not giving this to someone who's in diabetic ketoacidosis or who has, raging thyroid disease or whatever the situation might be. So Julie worked out some of the tests that we should order. And how did you come up with this list of things?
Just based on any of the contraindications, so the labs, for any of that. And then just generally just doing a whole panel. So that way, if there is anything that comes in out of range, you can then ask them to see their primary care physician and make sure that they get clearance. There have been a few occasions I've talked to other providers who have had a few people who, they did labs on and they didn't come back favorably, and their primary would not give them clearance. So I think for us in our practice, we're asking that if somebody has seen their primary care physician within 3 months, that we will allow that. They can have those labs sent to us. If not, then we will provide lab slips for them and send them to go to do that. And then once those labs come back, after all the health history has been done, all the consents have been formed, signed, all the teaching has been done, then we would go ahead and give them the medication. Yeah.
I think she's right. I think you have to take it very seriously and make sure your patients are healthy, because if you're prescribing medication and someone's in renal failure or some hepatic issues or, their liver function tests these are all contraindications to doing it. So unless you're a primary care physician or, have the labs, you really have to proceed very carefully here.
Yeah. One of the other questions that one of our nurses asked was, who's like the ideal candidate? And really somebody that wants to lose, between 10 and 30 pounds, I would say. If somebody is grossly overweight, morbidly obese, you would want to send them to their primary care anyway, because chances are they could get this covered by their insurance. Mm-hmm. So hopefully, you wouldn't be treating people like that.
Yeah. Yeah, stay in your lane, basically. You don't want to take on someone who's massively obese because they obviously have lots of other organ system problems, and we don't want to, get them into a worse shape. So, this drug was intended for diabetics, right, who are struggling to lose weight, who have decreased insulin production. But of course, a lot of patients are taking it now, like all of us who aren't diabetic, who don't have these other significant health issues. So just be sure that you're treating the right people, and if there's any issues with them not being totally well, their labs being out of whack, send them back to their primary care physicians so that they can be made well, hopefully, or be cleared to have this done. And don't take on someone that's begging you to do it even though they're not healthy. It just doesn't make any sense. You don't want to take that risk.
Yeah, for sure. Somebody.
Yeah.
I mean, look, there will be people whose primary
we're
care
discussing
physician.
Semaglutide and all the different versions of Semaglutide and some of that's what are you
Yes,
discussing
yes.
for weight loss, right? You
Yeah.
guys know all about that, hopefully. Sorry, go ahead.
I forget what I was saying.
Yeah, that's what you were saying too. We were just talking
I don't
about.
know. I forget.
Yeah, so we're talking about healthy people and people who were trying to force you to give it to them even though they're not
Right.
maybe healthy enough to have the drug.
Right. Exactly. Is there a BMI cutoff less than 27?
For insurance coverage, right? They want you to have a BMI up, 30, 27, 30, to have some issue, whether it's stage 1, hypoglycemia, hyperglycemia, some hypercholesterolemia, some secondary characteristic to get any kind of insurance coverage.
Right, but that's for insurance coverage.
Yeah.
For our purposes, I don't know that we have a strict cutoff. BMI is not a very good indication, in my opinion, for a lot of people. A lot of people will, go on and, a BMI calculator, and it says that they're morbidly obese, and they're not. Yeah. It doesn't take, into account a lot of variables. So I would say if somebody is healthy, if somebody's labs are fine,
Mongero's one of the same drugs. They're all in the same family. We're talking about the same drug.
Yeah.
Lots of different versions of it, but it's the same thing.
Yeah.
Sorry, go ahead.
Yeah. So I would say that if somebody's healthy, their labs are within normal range, they need to lose anywhere between 20, 10, 50 pounds. Mm-hmm. I'd say that that's fine.
Yeah, I think they're going by percent body weight, 10 to 15% body weight, loss. And the labs we're recommending are CBC, a complete metabolic panel, which would include hepatic enzymes, because that's really important as well. A TSH to just make sure their thyroid is functioning normally. A1C for obvious reasons to see if they're really diabetic and how severe it is, and the triglyceride level. If all of those come back fine, or if the patient's been to their PCP recently, they've all been fine. That's great. You can sort of move forward. If any of them aren't right, and they're of any significance, if their sodium is 142 rather than 140, I think you're good to go. But you know what I mean. So if they're not, send them back to their primary care physician. Let them handle it. Let them clear them or not. They can also put them on these medications. So, if you're running med spas, you're really cherry picking your patients, just like you're cherry picking your patients for the fillers and neurotoxins that you give. All of these drugs are conjugate. Yeah, we already talked about that.
Yes.
The protocol is you don't do it. You don't do the drug.
Yeah.
It's contraindicated. You just say,
you can't.
Sorry, it's contraindicated. I can go over the contraindications again if you want. Medullary thyroid cancer, multiple endocrine neoplasia 2, which is medullary thyroid carcinoma, parathyroid tumors, and pheochromocytomas, which are adrenal tumors, gallbladder disease, and I forgot one that you mentioned. And any kind of pancreatic issues, particularly recent, bouts of pancreatitis, because this stimulates your pancreas to secrete insulin, and you don't want to kick an angry dog. So Maddie just joined. So that's the panel of studies we recommend. If they're all fine, you can go ahead and proceed. It's very hard to get Mounjaro or Ozempic or...
Through your primary care. First of all, in order to have insurance pay for it, there are very specific requirements. And, in diagnoses that the insurance company will require. So most people will not get it through their primary care physician. That is true. Most people will not, which is why all these companies started... compounding them.
We're getting it from compounding pharmacies who are much more reasonable. They're not big pharma companies or smaller companies that make these products. So let me just talk a little bit more. Lipoline.
I don't really know.
I'm not sure about. Let's look that up while we're talking.
Okay.
I remember people talking about it. I don't remember exactly what it is. So here's how it works. So when you eat a meal, food goes into your stomach, gets kind of broken down, gets into your intestine and into your colon and then out the other end. While that process is happening, when you eat something, the body, the distal ileum and colon secrete this glucagon-like peptide, which activates your pancreas to secrete more insulin because there's a big load of food coming, a big load of sugar and carbohydrates coming. It stimulates your pancreas to lower your blood sugar. It also sends a message to your brain that you're full. Hey, we've got food here, we're good. The colon's, the ileum's distending, we're good. And so now this happens by just injecting this drug once a week. So it's like telling your body that it's full all the time, that you're not hungry. So it's kind of easy to lose weight. If you could combine that with a healthy diet, like we're talking about, and a little bit of exercise, it just like zooms like crazy. What was the question?
So for the one who just asked about coming down on the compounding, there are different compounding pharmacies compound it differently. And you can, I mean, I probably get a fax a day from a pharmacy asking if I want to order it from them. So you can be pretty choosy about which compounding place you go with and what they add to it. Ours do not, ours is the pure form. One of the, some of them add the same protein in that Ozempic does. Some of them add B12. Lipoline is not a prescription. Semaglutide is. So for whoever asked about the lipoline, I think that's more of an anecdotal treatment, if you will.
And the other thing is that we all, like we have 15 or so of us in my office that are on it now. So we wanted to vet it ourselves before we gave it to patients. So we're all on it. We were just on a chat group discussing like what our, adverse events were, like who's having nausea, who's having headaches, who's not having any symptoms, so that we all are on it. And the thing is, if you're on a certain dose, and again, you start out at 0.25 milligrams for 4 weeks, then 0.5 milligrams for 4 weeks, then 1 milligram for 4 weeks, then 1.7 for 4 weeks, and then the fifth week you start on the end dose, which is 2.4 milligrams. You can stay on that for as long as you need to. Then we're thinking that if you are getting to your goal weight, you may still want to be on a maintenance dose, and we're not sure yet. We haven't gotten there yet.
For a couple months. This is what's in the lipoline. It's all just vitamin B, basically, L-carnitine. It's more like something you would probably get at, like GNC.
Like a fat burner kind of thing.
Yeah, kind of like that. But it's not.
So this is more powerful. This is, some hormone in your body that you're sort of manipulating a little bit as you're shutting it all down. So this is way more powerful than lipoline and much more effective, I believe. So that's kind of how we see it. Like we feel like it's something that you should take a lot of care when you're evaluating your patients. You should do a very thorough history, get these labs that we just mentioned, CBC, complete metabolic profile, TSH, A1C, triglycerides.
And a lot of patient teaching. I mean, you really need to spend time with your clients, with, teaching them about the product, teaching them what to look for, teaching them how to do injections, doing weights. Everybody can roll out the program any way that they see fit, but, some people will want to require weekly check-ins, monthly check-ins for sure when you're increasing your dose, but of course always available, and having a physician or an NP or PA that can, field questions.
The other thing is if patients, again, all patients are different, and some patients have no side effects, adverse events. Some people have problems right away, but there's always some kind of GI issue because you are affecting the GI tract. If you're having trouble getting to the next dose, like if you're like, I'm okay at 0.5, but when I go to 1, I know you can stay on 0.5 for a while, for a few weeks, and then sort of gradually, your body will adjust to it and gradually go up. You don't have to do it every 4 weeks.
Yeah.
And, I probably shouldn't even tell you this, but one of my friends.
Well, yeah. I mean, you can, though, because you're going to say that he went up sooner, or he started a lot higher.
Yeah.
And that's, exactly. And it makes sense because the dosing that we are using is the dosing that was FDA approved.
Right.
So just like Botox and other things that we use off-label for different areas, you can change the dosing based on,
clinical need or the assessment of the patient. Like one of my friends, his wife is a doctor, and she started her own semaglutide program, and he came home one day. She said, "Oh, let me see your stomach." But, you look like you got a little bit of extra weight there. And she sort of reached around behind her and she stabbed him in the belly with the needle.
Because he's afraid of needles.
Because he passes out if he sees needles. He's like 6'4", 220, but like the sight of a needle makes him drop. And he's a guy that was in the military and everything. And she started him at the 3rd level dose.
She started him at 1 milligram
instead
of 0.25.
And he hasn't eaten in weeks. Like he's just like
okay, he eats, but
you know what I mean. But maybe she thought because he's a bigger guy, like she could, start there. But I can tell you, like even after the very first day, you feel something. How are we pricing it?
So you're going to have to everybody's going to have to do what's right for their practice. The way that we've decided to do it in our practice is we're going to have a 2-month pricing. So they can sign up for 2 months and pay one price. If they sign up for 5 months, it's a little bit of a discount. And then maintenance, because once they're at 5 months, that dose is going to be the same. So we base the pricing on what we're paying for the semaglutide. All the time that we put into developing the program, I have patient protocols. I did protocols for the caregivers. We're also providing the sharps containers, the alcohol wipes, the insulin syringes, in your time, of course. So you want to, put all that together. I also did a lot of research on, I know personally many people, including family members that are on it, prescribed by their primary care physician. So what does it cost, those people? What does it cost somebody who can't get their approval, can't get the pharmacy approval? I know it was $1,500 a month for Wegovy out of pocket for somebody who couldn't get it covered by insurance, which is pretty steep, but people were paying it. So, take all those things into consideration. Our pricing is going to go something like $1,300 for the first 2 months. If they sign up for 5 months, $29.99, and then I think our maintenance is around $400 a month, something like that. So,
are you drawing up weekly doses and giving it to the patients?
No, we are teaching them how to do it. If they want to come in for their first dose, I know some people, if you want to require that they come in weekly, then you certainly can add that in as, an a la carte menu. They can pay an upcharge for that if you want to see them weekly and you're doing their injections. Most people will be able to do it. And depending on the compound that you're using, it's not a lot that you're injecting.
Katrina says, should you be changing your diet on this medication? I think absolutely, because you are going to be unable to eat very much. So if you're going to eat protein, eat something that's healthy. Like, you won't want snacks. You won't have that craving for like sweets at night or whatever it is. Alcohol seems to have, people I've talked to, it doesn't really affect, it doesn't get them drunk. The girls in my office were complaining about, I had 3 drinks and I didn't feel anything.
Well, but some people complained about the opposite too.
Yeah.
So
definitely,
you just don't really know. But if you're not gonna eat a lot, then you shouldn't just eat a piece of pizza for the whole day. You try to have something healthy. Obviously, fruits, vegetables, lots of protein.
And honestly, even small amounts fill you up. So eat some fruit. Eat stuff that's healthy, and also maybe take advantage of the time and do some exercising, because make it really worth your while to do this.
So someone asked about time limiting.
Yeah.
So here's the thing: people who have to lower their A1C or are diabetic can stay on this for their whole life,
rest of their
right?
life, yeah.
So it's not. If someone has to stay on it longer, shorter, it's not going to work the same for every person. 5 months is when you're up to your maximum dosage. I would say, I'm going to guess that people will probably be around it. We're just starting this. I'm going to say people are probably going to be on it somewhere between 5 and 8 months. And you can taper off of it the same way that you kind of increase. And then, maintenance. But I think that because your appetite is less, if you can develop and encourage your clients to develop some really good habits while this is happening, that's going to go a long way.
And your stomach kind of shrinks down. You just start living a little bit healthier lifestyle because you're not looking for food all the time. It's just a bizarre thing. Your brain chemistry changes a little bit too. You look at food differently. In fact, I usually have like a salad for lunch every day. I literally get like maybe halfway through my salad, and I haven't eaten anything for breakfast. I haven't eaten anything since the night before. I get halfway through my salad, and I look at it, and I feel like, get this off my desk, throw it away. I'm repulsed by it. I'm just repulsed by it. I don't know why. I don't want it on my desk.
I never want to get off it. That's what people are saying. Like, for the first time in their life, they're not a slave to
their cravings,
their battle with, oh my God, I want to eat this, but I shouldn't. And they're just feeling so good that they have a little bit of control. Now, something's helping them have that control, but so what? So many people really need this.
Yeah, I mean, obesity is the great battle for all of us. Just being overweight, and it's such a detrimental.
Even if you're not obese, it's so hard for even the people who want to lose 10 pounds
Yeah.
that just can't.
Yeah.
Especially women, postmenopausal. It's really difficult.
You can look at it two ways, and you can say, look, I'm gonna, I want to lose, let's say, 15 pounds, and maybe it takes you 7 or 8 or 10 weeks to get there. Then you're like, okay, I'm at the weight I want to be at. Then do I want to go off it and, then maybe go back on this diet again next year? Or do I want to just keep taking small doses? I mean, we don't really know that yet. I mean, now that everybody's doing it,
Yes, Wendy, you are absolutely correct that nutritional education should absolutely go along with it. And somebody just said, are you going to dose them so that they have zero appetite? I don't think that's a great way to live either.
No, you need to eat. Yeah. You need to get protein or you'll start losing all your muscle mass, right? You still need to eat and still get calories and protein in your body. But just in controlled like for me, it's really about just portion control. I mean,
you don't want to take away all the joy in life.
Yeah,
I mean,
you still want to enjoy the food, right? I had a couple bites of dessert last night. I had a little bite of bread, but that was good because I was saving some space for my steak, right?
But you have some control over it, which is nice.
You control it, right? Your cravings don't control it. Yeah. Wendy wanted to do some work with us. I remember you talking about this, Wendy, about diet. Stuff. This may be the time because we're just about to launch this, so maybe you can connect with us tomorrow.
That would be great.
And congratulations on all of your new developments. I enjoyed reading your email today. I really appreciate that. Patients can stay on lower dose if losing weight. Yeah, I mean, of course you can. You can stay right where you are. You don't have to go up. I mean,
Someone just asked me, a friend of mine. She said. She's still on the lowest dose. She's lost 8 pounds. I think it's been 2 to 3 weeks. She said, "Do I have to go up?" She has quite a bit to go up to lose. So, I would say for her, I would like her to at least go up one more time.
Yeah.
And see,
Yeah.
Because I think you probably will get to a point where you plateau.
Yeah.
So
I guess overall our message is this seems like a great drug. Our experience has been a good experience. No one in our office has had to stop taking the drug or stop progressing up the ladder based on adverse events or anything like that. We want you to also be sure that you really screen your patients and make sure they're healthy enough to do this. And if there's any abnormalities in their labs or any question about their health, send them to their primary care physician and make sure they can get cleared there. We're using the not the generic brand, but the compounded pharmacy, just because it's impossible to get these other name drugs from the big pharma companies. It's just the demand is way outweighing supply. So these other companies have come in and stepped up. We vetted all of this with our own bodies and our own diets to be sure that these drugs were safe and this was a good compounding pharmacy. We like it. We think it's great. The pricing is much better, and we're sharing that with our patients as well. There are some contraindications that I mentioned, medical contraindications.
Someone asked where we send them to get labs. So we have the lab forms for people that are in MAA. I know not everybody on this forum is part of MAA. For us, we will personally be checking the labs, so it will not go through the DASH. It'll go through our office. We have the lab slips. They will be at MAA.
They want to know where they send them to get the lab. You can send them to...
the lab slips are specific to Quest. Because we have a login, so we can check them.
So they can go to Quest and have their bloods drawn, or if you
they'll take the slip and they'll go to Quest. We will not be drawing the labs.
Yeah. Okay. Yeah.
They will be going to the lab. Yeah.
So it keeps it really easy. And then you get the lab results back in a few days, and you can review them. What farm are you using?
So 2 different ones, because of ease of ordering. We are using Empower for the medical practice, and I'm using that because it's just easier for us to do in the office. It comes,
the
dosing is a little bit. The dosing is the same. The reconstitution is different, and the way they supply it is different. So for the office, it's easier for us to do that. For MAA, we found some place where you can order it not patient-specific, and it's not reconstituted, which means that it doesn't have to be refrigerated. When I order it for patients in our office, it comes refrigerated. So it has to be shipped a certain way. That would be pretty impossible for us to do it for MAA. It just the hurdles that I came up against trying to figure out a system that would work for MAA, this was the best system that would work. So for MAA, it's Olympia Pharmaceuticals. And for our office, it is Empower.
Are you planning to cap the patients you will have in the program?
No.
We haven't really thought about that.
If we can't service them, I guess.
I mean, honestly, once you teach them how to inject, they're pretty much on autopilot. I mean, we used to run an HCG program where people had to inject every single day. So you can't see patients every day for this. And they did really well on that. It was like an intensive educational thing. They can call with questions. They could do it FaceTime if they weren't sure. But everyone did well with that. We really liked the program.
Yeah, there's no cap, and I think people aren't going to stay on it forever either. So,
MAA, yes. This is my first time on the line. Well, it's about time you got here.
What does it say? Would we pick up at MAA? No, we will. We have to order it.
We'll send it to you.
It has to be a physician that orders it. So
it has to come to us.
We will order it.
We'll write the prescriptions, get the products, and get them sent over to you. Our patients want to come in weekly, but I mean, there's not really much to
if they
do
want
or talk
to, though. I mean, there's a premium for that. If they want to, they could.
Maybe there's an upcharge for that.
Well, you could change it to Zoom weekly. I mean, for us in our practice, we are giving people the option, but I think we are going to encourage the first 2 visits in person, monthly in person, weekly by phone or Zoom. That's how we see it working for us. But certainly, if somebody really wants to come in and get weighed weekly, that's okay. We'll make it work.
I think they'll get tired of coming in weekly because you're not really doing very much for them. It's really like sort of in my mind.
Some people like the accountability.
Yeah, sure. And if those patients want it, I mean, obviously you have to do it. I think most patients, probably won't once they get the hang of it.
Yeah.
I'm good to go on this.
Sorry.
All right. So we're again we saw our we rolled it out to our first patient today, and we have some more on the list tomorrow. People have been waiting for it. So we'll check back in a month or two to let you know how we're doing and what's happening.
Yes,
but we're very excited about it.
Yes, glow on me. Tuesdays and Thursdays, I believe, is when you can order for Olympia, but their turnaround is very quick.
Very quick. Yeah.
So.
Yeah. So we're excited. We hope you guys find it to be something that's worthwhile for your practice. I mean,
I can take one more question.
Oh,
Does
go
using
ahead.
the non-reconstituted form extend the date of use? So what I have found is even when I order it patient-specific and it comes refrigerated, everything says 28 days, get rid of it. But I have to tell you that the expiration date on Empowers is 4 months.
Yeah.
So
it's interesting.
It can last a pretty long time.
Yeah. Like, the vial that I have, this is my 7th week injecting, and I'm still on the same vial.
Yeah.
Because I'm injecting such small amounts, in the beginning.
Olympia is not going to be quite that because you do have to inject a little bit more. So Olympia, you will have to get more. When will it be available for MAA? Very, very, very soon. Like very soon. Probably this week or next week. Victor is going to put together some informational sessions for MAA members.
So we'll have roundtables like
Cash
this.
flow officials. So they've generated over 6 figures with the medication. Wow.
That's fantastic.
Good for you.
That's fantastic. Where are you located, Cash Flow Official? Dr. Russo, have you seen weight loss? Yeah. I didn't really weigh myself in the very beginning, but I kind of sort of guesstimated and extrapolated backwards. I think I've lost about 10. At least 10 pounds. And I started, 176. I'm down to 166. And I'm not really doing anything different.
My son has lost 30 pounds on it. I haven't met anyone who hasn't.
They help patients lose over 450, but it's fantastic. Fabulous. If you have any tips for us, let us know. You sound like you guys are doing a great job, and we appreciate that feedback. Yeah, Baltimore. Okay. Great. Yeah. Well, thanks for joining from Baltimore.
Thank you, everybody.
I appreciate that. If they're
we're gonna go eat.
We're gonna go chow down. Thank you all for joining, and we'll see you. Pretty much every Tuesday night at 7. I'm the aesthetic mentor. This is my wife Julie, and let's talk soon. See you guys.
Bye, guys. Bye.